We've got one more talk before the break. I'd like to welcome Sarah Glass to the stage.
Thank you so much, Amy. So I think it's important to start and just really recognize the fact that every single data point that we're collecting here, we acknowledge it represents a name, a face, an experience, a fight for a better treatment, a better life. We acknowledge and recognize the fact that every time each of us have to take our loved one to these visits, it's a lot of work. And so it's our job at n-Lorem to ensure that we're collecting the data in a very rigorous manner, that we're ensuring that the data can be aggregated in a meaningful way. And ultimately that enables us to translate this story as told by data into meaningful outcomes. And it's really changing lives, and each of you are a part of that. So that's really what I'm going to talk about today in the next few minutes. I know everybody's ready for a break, so thank you for bearing with us. My name's Sarah Glass. I'm the Chief Operating Officer with n-Lorem. I think what that means is my job is to take Stan's dreams and try to make them happen. It's a real privilege to be able to do that. And I think I'm also a parent of a child with the N-of-1 mutation, and I mention that because this is not abstract, right? This is personal, it's important. Collectively, the n-Lorem team recognizes the importance of every single data point. So I want to really recognize and connect the dots from the morning. So why am I closing this session? We heard from Olivia just now about the power of one, right? We heard from Neil about what you can learn and what we're trying to do for subsets of patients, for this ALS patient population, how we're thinking about them collectively to ensure that we can try to help more patients more efficiently and much earlier in their disease. And we started off earlier with Lori looking at a holistic picture of the nano-rare patient population. All of this has in common that this is high quality, longitudinal clinical data. The clinical data is really one piece of the collective data that n-Lorem is collecting. It's important to acknowledge that today we have an unprecedented volume of data at n-Lorem. This spans for the hundreds of patients that we're working towards treating, for the millions of ASOs that we've tested. And it's really important for us, and this is a recurrent theme that you'll hear from us today and tomorrow, is that we're doing everything we can to take each data point and to be able to learn optimally. So it's important that not only are we collecting this data, but it's collected in a high quality manner, that it's in compliance. We also recognize, and we'll talk a little bit more here about data sharing. And so want to comment on our perspective on data sharing. It's really and truly non-negotiable to share this data, recognizing again, each data point matters and ensuring that we're learning optimally and the community can also do the same. And ultimately that it's time critical. So what data is shared at what point in time to ensure that it has a meaningful impact that is really intended. Also, we've talked a little bit about long-term care and the data that is collected long-term. And ultimately, all of this comes together because we recognize that concrete evidence is really driving the progress for all of you for this nano-rare community as we move forward. Oops. So I'm just going to touch on defining the data. What are the implications for all of you and for the patients and families that we're hoping to serve? Really data sharing and closing with some conclusions and lessons learned. So defining data, it seems like a really simple, straightforward question, but it's actually not necessarily always as easy to answer. And so at n-Lorem, we really think about the data that we're collecting in the terms of our process. And so you heard a little bit from Lori about what this process looks like in this discussion now and also in the one that I'll be sharing later, really looking at this process in sort of 4 different core steps. The first being patient review and acceptance. The data collected at this point, it's the patient genotype data. It's the patient phenotype data. It's a really important decision, and collecting that data in a rigorous manner, ensuring we have a comprehensive data set is really critical. We're working towards identifying this optimal ASO. So we have hundreds of ASO designs, millions across the entire portfolio. We have all of the data from the in vitro and in vivo screening. We have the GMP manufacturing, and this is kind of telling the story to go from the patient mutation to that vial in the physician's hands. All of those steps generate data, and it's important that we're collecting it in a rigorous manner. So once we have this drug ready to go, we have to put together a data package. This is in the form of a research IND that goes to the FDA. We have internal documents, storage essentially to ensure that we're collecting all of, not just the submission. The submission often seems like, oh, that's where we're trying to get to, but actually the engagement with the FDA after that submission is pretty extensive. You can talk to some of our team members, and I think that's a really important thing that we're tracking and we're learning from every single point. And then finally, really on the clinical data. So you heard a lot about that, so we won't touch too much on the clinical data. But really thinking again about how are we storing the data. And so we've established data storage platforms and solutions across the board. We have a customized matrix application portal that the physicians actually apply to. That was created by Across Healthcare, who's one of our collaborators. We have the internal n-Lorem ASO design software, electronic lab notebooks, the internal integrated sort of document storage solution, and then the REDCap, which is something that all physicians use, and actually we're looking to use that globally as well. So you hear a lot about benefit risk. This is really the core lens, and I think we think about benefit risk all the time. And it's funny because I think benefit risk, you can start to translate that into your own daily life to some extent. You're like, is this gonna be better, or is this? So you really ultimately are really trying to make these benefit risk decisions, and each one is grounded in data. And this really enables us to make some of these research choices and the patient decisions. So once we've collected data, we have it collected in a very rigorous fashion, this high quality data, what are the implications on the patients and families, and why does it matter? Why does it matter that each of you sacrifice your time, and we acknowledge that energy and time and difficult situation that oftentimes has to happen to get to the clinician? On a patient level, specifically, again, looking to evaluate the benefit risk, enable that physician to make their treatment decisions, and make some adjustments in real time on that treatment protocol. You've heard in the cross subgroup, essentially really thinking about how are we optimizing what we're learning across different patient populations, and really being able to then think about the next patient that's coming along. As Neil just shared, patients don't have time. We know that's true in ALS and in others, and so how are we learning within different disease areas to really be able to accelerate the next patient's treatment? And then it comes to really that broader nano-rare population level where we start to look in aggregate and understand kind of how can we refine the treatment approaches? How can we understand and apply the n-Lorem expertise in antisense technology? Think critically about what are the molecular mechanisms? What are some additional assessments and advancements that we could actually make that would enable us to help more patients? But really at the patient level, what we're trying to do here, these are authorized research INDs. This is the FDA structure that has been put in front of us that enables n-Lorem to be successful, to move all these treatments forward, and we want to move from research to clinical care. And we're just now here in 2025, we've been in existence for almost 6 years. We're seeing a lot of the clinical benefit that you've heard about now, and that ultimately, you take the preclinical package, now we have clinical data showing benefit, and we're really aiming to move towards that clinical care. And ultimately, all of these are leading towards changes in healthcare as we know it. Thinking about mutations and not diseases. Really thinking more broadly, and how can we apply this to rare and even common disease populations over time. So we touched a little bit on aggregate data analysis. And so when we're thinking about how do we actually consider all of this data that is coming in, we have to look at the unique characteristics of each patient. You can see, obviously, we know each patient is entirely unique, but you have to also pull the threads that are common. And pulling those common threads is then enabling us to take kind of this platform approach and introducing a lot of these efficiencies. So this, some of these threads that we can pull for aggregation, the treatment goals, clinical outcome assessments, we're able to look at data across the board. Severity of different patients that may have same mutations in the same gene that can be, use the same ASO. Can we actually group patients together, put them in these regulatory documents? That actually translates to our regulatory strategy as well. And really thinking about the SNP that's also targeted by the ASO. And so how can we understand patient populations, trying to think about collectively, are there groups of patient populations within these individuals that we can put together to really move these treatments forward more quickly and efficiently? And this is an example, and we heard earlier, and we've seen videos of patients, but this is just showing you from several patients in the HNR and PH2 community, just giving you a sense of the breadth of individuality in each of these patient groups. These are the ages at the time of application, but really thinking about there are some things that are going to always be common that'll translate into commonalities in the protocols. There are, of course, many things that are unique. And so the opportunity with individualized ASOs is that we can actually evaluate those individual characteristics, and that helps, again, the physician make those treatment decisions as well. So putting together disparate data sets, it's really and truly an art, and I think Lori and the clinical team do a really fantastic job of doing this, and want to emphasize the fact that every data point, it matters, and the robustness of this large data set is really exceptional, and that emphasizes the point that every single visit, every single assessment counts, and it matters. An interpretation of incomplete data can actually introduce some complexities, as one might be able to imagine. And so it really makes the participation in the protocol even more critical as well. And finally, I think on the aggregation, it's really important that you're considering the ASO itself. So because ultimately, when you're looking at the treatment effects, you need to consider the quality and the provenance of the ASO to be able to accurately interpret differentiate the causation of these different treatment effects as well. So we've already heard a little bit about communication. I think I wanted to highlight and show, if you think about these two sweet girls, Susanna and Sloan here, and you look at their impact on communication, and we can think about the context of what we're seeing in the data that we're collecting.
And the beautiful Susanna takes the stage. Go!
A million dreams to keep you awake. Open your eyes. A million dreams.
Hey, Slenny, did you get your medicine in New York?
Yes.
How does your medicine make you feel?
Sure.
Strong? Oh, show them your muscles. Oh, good job. Let me feel them. Oh my gosh, they're so strong. But how are you feeling?
Bye-bye.
Oh, bye-bye? You want to say bye-bye now? Can you say thank you? Thank you. Say see you soon.
No.
Can you blow him a kiss?
Aww, yeah. So we just applaud these two young ladies. And I think it's important to, we just recognize the fact that both of these gals for sharing their stories, and to their families for sharing those stories. I don't know about you guys, but I've seen that video of Sloan and Susanna, and I get goosebumps every time. It's just so important. So thank you for sharing those videos to the families. But really, when you're thinking about, so what we've learned from those two is perhaps both individuals are seeing an advancement in communication. How do we know that, actually? We can't say that by looking at this video in isolation. So that's why we're really coming back to the crossover trial design. We're learning from a patient's pre-treatment. We're collecting the data pre-treatment. We're looking at data on treatment, like these videos, looking at the data that enables us to understand these videos, and we're able to then say, we're actually seeing benefit in the domain of communication in these two individuals. And again, that ultimately leads us to support the physician's treatment decisions. So I hope this is really helping you understand to emphasize the importance of the data that each of us is collecting. It's important for each of you in your own treatment protocol, but it's also going to ultimately help the broader nano-rare patient population. And this data has shown us at n-Lorem that we can do this. We can actually do this. We have the data to show that we're able to discover, develop, and provide these individualized ASOs equitably and safely as well. So now that we have this data, it's in a very high quality, high fidelity collected manner. It's important that we're sharing the data. And I think Stan alluded to this earlier this morning, and want to emphasize the fact that it's not just about data points that we're sharing. It's ensuring that whomever we are sharing the data with can understand the data in the context of what matters to them. So that's been a really important component of this sort of knowledge sharing approach that n-Lorem takes for the researchers, the patients, and the families. This is really aiming to ensure that the community is educated. How can we help each of us understand more? I know I have learned so much since joining n-Lorem, and I think every day we continue to be curious and we continue to learn so much more. And this is not only on what you need to know, what we're learning, but it's also on what matters that minute, potentially. So anything that we're learning that could potentially have an impact from a safety perspective, it's critical, and it's our responsibility to ensure that we're sharing that appropriately. And ultimately, this is giving attention to a patient community that literally didn't exist as a community just several years ago. So you can see here, this is just representing kind of what the key areas of data sharing that are critically important to n-Lorem. So ultimately, each of these really focused with that scientific rigor and transparency. But we have the education that we mentioned before. We have the lessons in antisense. I encourage you to listen to those. They're very, very interesting and sort of simplify something that could be potentially very complex. We have the podcast, many other facets that we're looking to really educate the community. Peer-reviewed publications are absolutely critical to really have that objective review from the scientific world, essentially, and that validation. This helps us broaden our scientific reach and ultimately helping more patients over time. Obviously, there's conferences. We're attending a lot of patient meetings these days as well. I think this has been really useful for us to be able to connect with different patient communities and try to understand what we're seeing with patients who are on treatment and how are we working together to treat more patients. And of course, this colloquium. We're thrilled to be able to have this and have all of you here. We planned for this. We'll probably start planning, what, Amy, Friday? Perhaps. Maybe they'll give us till Monday, I don't know. But really, this is a very important, we'd love to hear your feedback. What else can we do to make sure that we are all, as a community, positioned to ensure that we are sharing the right data? And of course, the safety bulletins, as I mentioned before. This slide is showing you several different publications. You can see these very sort of high value and high impact journals. We have many publications, and as these n-Lorem sort of ASOs are treating more patients, the number of individuals that are publishing is growing exponentially. So we're really doing what we can to ensure, and we continue to encourage all of our collaborators to publish as efficiently as makes sense, and when that data can be published in a meaningful and impactful way. So in the last few minutes, I just want to close really thinking about a couple of lessons learned. You've heard this through and through before, but each of you, each patient, each family, each experience is unique. We recognize that on a daily basis. We recognize it when we look at the data, even patients that are being treated with the same drug, and oftentimes even more with patients being treated on the same drug. We need to really understand what is different about each patient so we can interpret the consequence and the impact of that treatment as well. And this includes the long-term treatment management. And so we do expect that the management of each patient, and you heard a little bit from Olivia, you'll hear from Drs. Bain and Chung and several other physicians over the next 2 days, the treatment response, it does vary as a function of each specific patient's disease and their clinical manifestations. And this will all help us to really define, refine the dosing and all these expectations in real time. And I think this is a really important concept. So the way that n-Lorem protocols are drafted, most of the time they're 2 years. I think ideally we're looking to be sure that we can actually evaluate several data points from pre-treatment to several data points on treatment. So what happens at the end of 2 years, right? That's a question we get oftentimes. Well, the way that these research INDs work with the FDA is that they actually stay open. So n-Lorem will continue to work with the physician to collaborate to enable the treatment and the dosing, to work towards continued dosing and a maintenance dose. You might imagine that at the end of 2 years, you decrease the assessments, you're on a stable dose, and there we go, and we continue on. It's actually not that straightforward, and so this is a really important component. It's n-Lorem's commitment to ensure that we continue the treatment as long as that benefit risk, coming back to that point again, is favorable. So we will continue to ensure that you have the treatment and that physician is able to dose you in accordance with what their treatment decisions mean. But there are many things that we're learning are actually contributing to the complexity of that maintenance dose. And they're listed here, but even just thinking about severity of disease. The kiddos, they're growing, right? They're growing, they're advancing in their sort of just general chronological age, and you sort of apply that and you mix it up with then a disease prognosis that might be uncertain, and you add a treatment. Those are all things we need to take into consideration as we look at a maintenance dose as well. Some of these other things as important, things that we're learning. Somebody gets COVID and they've made a lot of advances in speech, perhaps. They may take some steps back, and we need to be able to recognize, is that an effect of the ASO? Is that an effect of COVID? Those type of things are really important to differentiate as well. So in conclusion, I hope I haven't bored you to death about data, but really and truly, every data point, it matters so much. And n-Lorem is committed to high quality, high fidelity data. We're committed to sharing that data externally in very purposeful and proactive and meaningful ways. And this really enables us to have these meaningful conversations and collaborations externally. And if there's ever questions or comments or other suggestions, again, on other ways that we could collaborate, please feel free to reach out. All of us are accessible, and we'd love to hear your perspective. So we've really been able to pave a new path for healthcare. And I think each of you, just for being here, we are all pioneers. I think we celebrate the pioneer patients. We have the pioneer physicians and institutions. We recognize the challenge that each of you has overcome to focus on one patient. It's really and truly incredible. All of the families in this community, each of us are pioneers. And so ultimately, n-Lorem has been able to leverage the expertise and the team that we've built to have this integrated capability. The integration starts from the point of understanding the patient at the beginning, all the way through to that long-term treatment, and pulling the thread of that data all the way through. It's also equally as critical, and that's taken us to be successful in these regulatory improvements. I think we really understand now that we're able to tell each patient's story through data. We're translating that story to meaningful outcomes. We're able to change lives. And we're really establishing the basis of this N-of-1 clinical science. And I just come back to the fact that every single data point matters, and we will continue to do what we can to make sure that each name and face and fight that we're all fighting together counts. So thank you so much, and I think we have a break, so happy to chat with you all over the break as well.